Okay, good afternoon, everyone. Welcome to another legislative week. Um, this afternoon, under our oversight and accountability, we're going to do a couple of updates on things that we had talked about here in the past and taken action on in the past. And we're going to be hearing from the Department of Disability, Aging, and Independent Living about a couple of different things. One, policy on payment to parents, another one on Meals on Wheels expansion and resources that have gone out there. So we are really happy to have the commissioner here. Welcome, Commissioner Bowen.
Yeah, thank you. Hi, Dr. Jill Bowen, Commissioner for the Department of Disabilities, Aging, and Independent Living. Thank you for inviting us to discuss the home delivered meals and the global commitment investment. And thank you for your support around making that a reality, as well as the parent payment. So we're going to start with the home delivered meals, or Meals on Wheels, as it is known. I have Jake. I do have Jason with me, who will share his presentation. So can you hear us, Jason?
Yes.
Okay, great. And he is our State Unit on Aging Director through the Adult Services Division, right, which it says right up there. So next slide, please. Okay. So just while she's pulling up the next slide, this is just a high-level overview. We wanted to first, since fiscal year 25 was the first year that Global Commitment was part of the Meals on Wheels funding package, we wanted to first just start with what sort of the last full fiscal year, which was 24, looked like. And that's represented on there. As we know, Vermont receives federal funding to provide home delivered meals. And this is for eligible Vermonters age 60 and over. In Vermont's case, the way that it works is the funding comes through Dale to the area agencies on aging, and then it's allocated to the many meal providers throughout the state, including to the senior centers. And there's also state dollars at play. In federal fiscal year 24, we received $1.8 million in federal funds. Those were through the Older Americans Act dollars that are highlighted for home delivered meals. And in state fiscal year 24, we had $1.3 million in state general funds that contributed to the home delivered meals and Meals on Wheels. And for the entire federal year, there were 8,237 older Vermonters that received home delivered meals. And I also always want to remind folks how critically important the volunteer contingent is for the success of the Meals on Wheels program. They do the majority of the home delivered meals, and most of them themselves are over 60. So if we go to the next slide, Jason, you want to come in with the specifics about the global commitment addition to the funding?
Yes. So hi, everyone. Jason Palapita, State Unit on Aging Director. So with respect to the global commitment home delivered meals funding specifically, for federal fiscal year 25, the conversion of $1 million in the state general fund for home delivered meals to the global commitment added approximately $1.4 million in federal match, which totaled $2.4 million in the global commitment funding. So each AAA has individual grants based off of this global commitment funding, and they receive this money for the grant term October 1, 2024 through September 30th, 2025. There is a requirement with this funding that each AAA reimburse their meal providers at least $6.50 per meal, and most are actually reimbursing more than that with this funding. They must ensure meals are provided to the most food insecure older Vermonters, and this includes those unable to cook, unable to obtain groceries, and those economically food insecure, or any combination of those. And it's important to point out that this aligns with the federal directives to target those in greatest economic and social need. So, for example, the Older Americans Act really focuses on targeting the most vulnerable older adults. Each AAA must report the number of participants that have 3 or more ADL needs. So individuals who have significant difficulties with, say, for example, dressing themselves and feeding themselves. Individuals who have 3 or more IADL needs. So examples there would be cooking and cleaning, and those at or below poverty. Each AAA must submit a quarterly report to the SUA 45 days after the quarter's end. And also included in the grants are options to use some combination of the funding for nutrition education, therapeutic meals training, and food safety certifications. So, for example, some of the AAAs have therapeutic meals training as part of their grant terms. And there's definitely a lot of interest, I think, for the AAAs and meal sites, and definitely within the SUA, to expand therapeutic meals and medically tailored meals for individuals. So, for example, meals that cater to those who might have diabetes, kidney issues, things of that nature. And for those AAAs who are interested in having this be part of the grant, part of the idea here is to kind of shore up and build capacity to provide those particular meals to individuals who could benefit from those nutritionally. For the nutrition education aspect, AAAs would need to partner with a registered dietitian or nutritionist and organize and fund at least one nutrition education seminar at a senior center, for example, that will educate participants who go to the senior center and who will be interested in learning more about nutrition on things like the relationship between diet and disease prevention and disease states and progression, and how therapeutic meals tailored to certain medical conditions can help improve outcomes of chronic disease. And the food safety certification piece, obviously very important for every senior center that provides meals and every meal site to have staff there that are in the kitchen cooking, et cetera, to be food safety certified. So those are some things that we included for these grants, just to, again, build capacity for medically tailored meals, provide the option for the public to learn more about nutrition, and to make sure that all staff and volunteers at the meal sites have food safety certifications as they prepare and cook the meals.
Thank you. Next slide. So while she's pulling up that slide, let me just say the $1 million in state funds that got moved over allowed for $1.4 million in federal match. So the global commitment total for the year is $2.4 million. The state funds get included when we speak about global commitment. So what this represents is that quarterly report that Jason was referencing. And so far, there's one quarterly report. The next one for Q2 is due mid-May. But you can see here that we get some interesting information out of the first quarter report from the global commitment money. Nearly 3,000 of the most insecure older Vermonters received 86,000 home-delivered meals through the global commitment funding. And that was $573,600 of the 1.4 and 1 million. All AAAs are on track to sustain this funding over the course of the fiscal year. So they are on track to be able to not run out of the money before the end of the year. And again, focusing on the most food insecure individuals, This is really incredibly important information because if you look below where it looks at all funding, so all funding sources in Q1 served, almost 4,200 people. So you have about 3,000 being served through Global Commitment, 4,000 total. And so what you're seeing then is about 3/4 of the individuals served meet that most vulnerable population definition. And I think that's going to be important, useful information for us to have going forward. The other thing that's important to know is that the federal match global commitment dollars are on 1-year grants that go through to the end of the federal fiscal year, September 30th. And that's what we know at this point.
We're at the end here, so I have Dan and Representative Garofano and Representative Eastis.
Thank you so much. Really appreciate all the work that you're doing to help older Vermonters with access to nutrition. I just had a question for clarification. So you're talking about nutrition education at senior centers. Is that one per AAA, like one day, or?
How does that work, Jason?
Yeah, it depends on the AAA. I'd have to look at each individual grant to determine like what they felt that their needs were in their regions. But just to give you an example of a couple of AAAs in terms of the nutrition education. So we have one AAA organizing and funding at least one nutrition education seminar or class per quarter, targeting older adults in that AAA's region, talking about the topics that I mentioned earlier. So I think that's for like 2 or 3 AAAs for the nutrition education focus.
Jason, the total number, you told us the total number of events that are served.
I'm sorry, what? I missed that.
The total number of programs that the AAAs are serving.
Statewide, the number of meal sites is approximately 40 across the state.
You had the requirements for getting the global commitment money of not, people needing to be 3 ADLs. But for the Older Americans Act money, isn't that just, the requirements are just that you be of certain age?
Yeah, so to clarify, the ADL, IADL piece is partly for reporting purposes.
Yep.
Someone doesn't need to have 3+ ADLs or 3+ IADLs to qualify to be most food insecure. It's data that the SUA would like to see to figure out like how many of those people, who you could argue are even more food insecure than those who say might have less than 3 ADLs. This is data that we'd like to see to perhaps kind of plan for any type of like future initiatives or anything like that. With respect to the OAA kind of eligibility criteria, it's very broad. I would say the gist of the Older Americans Act when it comes to eligibility for home delivered meals is a person who is over 60. And then they give a wide berth to states to further narrow that criteria, based on assessments and based on where they feel meals should go in terms of the particular kind of needs of their populations.
Thanks.
Senator Garofano.
Thank you. Can you tell me, with the reporting that you're doing, are you tracking like where the need is, like by geography, to kind of determine future grants?
So the AAAs are, right, each one of them is in a different geographic area, as you know, right? So that helps us determine where there is the most need. and where there's the most people, some of which we may know intuitively. But do you want to say more about that data coming through the AAAs and comparing across the AAAs?
Well, to determine the eligibility criteria as far as the stipulations of the grants are concerned, the AAAs do conduct assessments, and then the need is based on those assessments. So there are different categories that describe the different types of needs. So with these grants, like I said, we had the AAAs prioritize certain categories that result from these assessments that they conduct with potential home delivered meals clients.
And they each get different amounts of funding. So we have, yes, and what their historical needs are.
So I guess I'm just wondering, like, are you planning on doing like analysis on the data that's coming back to figure out if the need is matching the grants, like in future, like it feels like we're gonna have more like robust data now, and what kind of analysis are you planning for that?
Right. Well, the global commitment brings with it certain requirements that allow us to do a bit more analysis, but yes, that is important for us to do, probably now more than ever.
I think what I'm understanding you to say is, will there be any adjustment to those
Right.
allocations and the five based on the data?
The use and the data that you're receiving.
Yeah, I mean, so there should be, but we also want to make sure that come October, when we actually still have the global commitment dollars. If not, our expectation would be to go back to what we had fiscal year 24, right? Because it's not necessarily more people that we're serving through this. We're just serving it a little bit differently. So we want to make sure that, we have that for the each coming year before we know exactly what we're going to, we're going to target what we have to do for global commitment reporting responsibilities, and then take another look specifically about what is happening, even with the non-global commitment monies, but all funds.
Okay, okay, Representative Eustis?
So you may be getting at my question. I just want to understand kind of the overall picture. I can't quite tell how apples and oranges the information is here. So in 2024, I see a total of $3.1 million being spent on HDM. And this year, it looks to me like it's 2.4.
No, it's 4.5 because the 1 million, it's 4.5. It's an additional $1.4 million. It's
an additional.
Right.
That's what this top line is explaining.
No, you're looking at which slide are you looking at?
Slide 3, I guess.
So slide 3 is a quarterly report. That's why I said it out loud, because it wasn't on the slide specifically.
Okay.
Okay, so we gave you, if you look at the first slide,
Yeah.
that might be more illustrative.
Yeah.
Yeah, right, slide 2.
Sorry.
No, it's the right question.
And similar question, trying to parse the numbers from different slides.
Right, which, I said, oh, this morning we could have put it on the slide.
There's so many ways to put out information.
The 1.8, 1.3 plus the 1.4.
I see.
That's exactly what it is. So can you pull up slide 2, which is slide 1, really, the cover slide, and then
plus the 1.4.
Right. So
totals.
Right. So in the 1.8 million in federal funds contained the first.
Next,
that's the third slide. Wait,
yeah.
One more. There you go. Okay, so no, you went back again. It's the first slide. It's slide 1. Okay, so here you see that there's 1.8 in federal funds that continued because that's OAA dollars. So that just continued, the 1.8.
Right.
Then the 1.3 in state, 1 million of that. Can you go back again? Again, one back again. Thank you. Okay, in the 1.3 million, 1 million of that went over to global commitment and 0.3 stayed.
Oh.
And then the 1 million was added by another 1.4. So
Okay.
you're only adding the 1.4 to this to know that the total increased by 1.4, which got us to 4.5.
I see, okay. Okay.
All I had to do was put it on the slide, but I had it in my head.
Thank you.
No, thank you. It's the right question.
Follow up on some of this data and then.
Go ahead.
So, on the slide number 2 that we have up on the screen, it references 8,237 older Vermonters.
Yes.
And then if on the last slide with data, there's both 2,956 of the most food insecure served, and then all funding 4,193. So that's just a quarter. So we're going to double this year. If we multiply that by 4,
Okay.
we anticipate roughly, oh, we're not going to multiply.
We're not
We're not-
going to multiply
Oh, by
it.
4, right.
We're not going to multiply it. It's definitely, the reason that you see something like that is because many of the folks
Sure.
continue over from one quarter to another, but not all of the folks. And there's a fair amount of variability because some people may go into long-term care or some residential setting and they'll come off the rolls, and others will end up being in a position where they need to come on. So there's a fair amount of variability actually from quarter to quarter, but at the end of the day, for fiscal year 24, there were 8,000. So you can't look at it like 4 times 4, right?
Yeah, my mistake.
I did the same exact thing you did. That's how I know to speak fair.
So while we're on this slide, I'm just curious. So we have about 70% of the people qualify as the most food insecure, and they received 86,000 home delivered meals. Yet there were 234,000 meals in that same period of time with all funding. Obviously, there were some congregate meals in there. It just seems like 70% of the people receive far less than 70% of the meals, which,
Talking about the 86,000 is
Yes.
included in there.
yes, doesn't make sense to me.
Right.
Yeah,
Do you
so
understand what I'm saying?
yeah, so out of that 4,193, let me put it this way. The most food insecure individuals aren't just part of that 2,956 people. There are still going to be people who fit into that most food insecure category that received meals outside of the global commitment funding. So part of this is because we want to sustain this money over the course of the year, and make sure that at the very least this money targets the most food insecure. It's going to be drawn out over the course of the year, but just because you see more meals there with that 4,193 doesn't mean that those same categories of people weren't served by those additional meals.
It's a strategic effort to use global commitment funding more slowly. That was what I was trying to get at earlier. So it's 2,956 received some global commitment funding as a source of their funding, right? So we can identify that 2,956 were eligible for that, but they also are included in the 4,193 down here. And so they received meals that were funded through OAA and other sources because they're eligible for that as well. So it's a slower roll of the global commitment funding to make sure we can spread it out over the full year.
So I understand that. It still seems like for those, and I understand that the most food insecure are part of all funding, so I get that they're part of the bottom. Does that mean that those 2,956 people received more than 86,000 more than 86,000, or is it just those two things are included in
They
the?
received more. They received more, just it was a different funding source. Mhm.
So that's
Correct.
only what they received through global commitment.
Right, through that funding source. Yep.
Okay. So So my second question is, I guess it's related to Representative Noy's question. So it was helpful, Jason, that you said that the 3 plus ADLs or IADLs are not an eligibility requirement. It's just you're collecting data. Is that right? Did I understand that correctly?
Yes.
And so are you only collecting that data for folks whose meals are reimbursed by Global Commitment, or are you collecting that data for all individuals?
All.
Okay.
But it is a requirement of the global in order to continue to receive the global commitment funds.
Okay. It's just reading through this, it makes it look like it's these folks in particular have some sort of higher level of eligibility, which that is not what I'm hearing you say.
Well, if you are receiving the global commitment funding, then you're eligible for Medicaid, which speaks to some of the financial.
Right. Yeah. Yeah. And then when you say poverty, at or below poverty, what does that mean? I mean, what does it mean? Is it like 100% of poverty? Is it 120% of poverty? Is that
Specified out specifically, or is it if you meet Medicaid eligibility, Jason?
I believe what we settled on was the federal poverty level.
Yeah,
Although
which
I
we
don't have that
right here.
in front of me.
But I didn't know, are you saying at 100% of FPL? So for, a household of one, that'd be $1,304 a month. Are you saying at 100% of federal poverty limit?
I believe it's 100%. It's whatever we track for our OAA federal reporting as well.
So we could get that exactly.
So we don't
for
know.
you.
I don't-
Yeah, you don't know that off the top of your head. Let's just get that, Jason, and we can send it in.
Okay.
I like that you have that on the wall, but.
Well, we refer to it quite a bit. Did you have another
Yeah,
question?
just
Go ahead.
another quick question. I'm just always thinking about our federal situation and the ability to draw down funds. So we're in a continuing resolution with the OAA money. Have you been able to draw money down against the CR so that?
We're not having any problem right now.
Okay, that's great news. Thank you. And then the Medicaid is still the
Not
same.
having any problem with that either right now.
Great. Thank you so much.
Okay, any other questions from members? Okay, great. One of the, I guess, final questions is in the enacting legislation, and just for members of the committee who are new to this topic, prior to FY24, the state actually didn't put it, we in this body didn't put in much of any money in general fund. And so we added that $1 million. And then we said in 25, let's match that up with federal funds if we're able to. Department figured out how to do that through Global Commitment investments. Investments are one of those things that's on the potential risky area. And it's not just this, there's a very long list of investments in Vermont. But one of the things that, and I think that there was a group that worked on this, not this past summer, but the summer before when we gave out the original first $1 million, is about showing that there was some equity in making the allocation to the various regions of the state. And I'm just wondering, and you said that that we're reimbursing people, meal providers, a minimum of $6.50 a meal. And I'm just wondering if we took a look at how was equity defined in that process, when you came up with the allocation process, because this was something new because we didn't have these state funds there before, and now it includes Medicaid. So I'm just, and this was, I think, before your time, Commissioner Bowen. So
1 year.
yeah, yeah, I'm sure it feels like a lot longer.
Both that and shorter. Yeah.
And Jason, I don't think was in his position at that time either, although he may have been, I don't know, maybe involved in the discussion. So I don't know, maybe we don't have people here who can reflect on that. But there was language in the enacting legislation that really called about looking at how these funds could be distributed equitably. And that wasn't inferring that, dividing it up by 5 and sending it out to 5 AAAs. And I'm just, if you don't have access to that off the top of your head, which I don't necessarily expect you to, it'd be great if you could get back to us about how that formula is used, how it's, maybe it's been modified in the ensuing year. Just how are you determining what each AAA gets in order to, send out to the local meal providers?
Unless you know the answer to that, Jason, let's follow up.
I can look into that. I need to investigate that a little bit more.
Okay, thank you.
Because they don't all get the same amount. That's
Right.
Yeah.
Right, yeah. And I think that there's definitely, I hear from my local senior center, I'll be honest, on a pretty regular basis, that they're not, they appreciate the extra funding. They're wondering why more of it doesn't come to them. I'm not sure if they see the benefit of these, classes, they would prefer that money came to them in meals and not in that. And I think, there's that old saying about teaching an old dog new tricks. Sometimes it's not easy to try to teach, 80 and 90-year-old people who've eaten a certain way their whole lives to, they're not necessarily going to change by taking one class, if it's even offered in your area, if it's one class a quarter per agency.
Someone may be able to teach the class.
Maybe, yeah.
Have all these experience and
Yeah.
wisdom, but it is a requirement in order to get the global commitment dollars, as I understand it. That being said, I'm also interested, based on what you're asking, because the flow from Dale to the AAAs to like the senior centers, that we need to understand how they're determining who's getting what. So we'll follow up.
Yeah, yeah. And I mean, we set the requirements
Mhm.
in global commitment,
Yeah.
so it's not, the feds didn't set that.
Well, so do you want to pull back on that? I mean,
I know, I'm just saying,
Education. It's the negotiation with the feds in terms of what it is that we will be
able to,
Yeah.
yeah.
right amongst, the things that they.
Well, I would just say that it'd be great if you could minimize the amount spent on that other stuff and maximize the amount that goes out for meals.
Maybe we can do that next year if there's actually.
If there's
next year.
actually global commitments.
If there isn't, just we'll keep an eye on that $1 million that moved over from the general fund.
Yeah.
It just reminded me of another question. Where do you see Meals on Wheels in kind of the bigger picture of must fund? Should there be changes coming from the feds?
That would be speculation, right? I mean,
But if it was to change, does the department see Meals on Wheels as something that's a must fund?
So I don't know what must fund will mean until I see whether we're talking about something that's a minor disruption, a major disruption, or a catastrophic, disruption. So not knowing that, it's
Yeah.
hard to say, this over that, because there are so many things that are in the department that are really life-saving or life-changing or quality of life impacting, that before knowing really what's at risk to say, oh, yeah, so, we're not going to not feed people, certainly it's a high priority, and we're
Right.
thinking about that, which is why looking at 24, which was before the global commitment, and seeing what's really changing with this extra money is really important, because if we're not reaching more people with food and doing some other things with it, that's less of a concern than if we're like expanding the number of people who now have access to food that didn't have it before. Those are two very different scenarios. And so, it's still premature with 1 quarter in to really even understand that. So, ask me again
Okay.
when we have a little bit more. Keep in mind that, as May comes through, we'll know a little bit more,
Mhm.
but it's not until the fall that we really know. Okay.
So it's making sure that this population has access to nutrition that doesn't have, always thinking about it.
I know, and
The fact that you
I,
are as well.
I can't tell you how much I appreciate that, because we always know that you are right there, right in the middle of it, so thank you. Thank you all, really.
And just to be clear, unless we made a different policy decision here, if the global commitment part goes away, the $1 million in state funds that we added, and yeah, I think it sounds like you had 300,000 that you're doing.
Yeah.
You know, at least the $1 million that we had specifically allocated, we would have to make a different decision here if that were to come to fruition. And like I said, so many things we don't know right now. So,
Right.
okay, any other questions about this area? Okay, go ahead, Representative Bishop.
You say make a different decision. Can you say a little bit more?
I'm just saying, we made a specific decision, a policy decision from the legislature to allocate $1 million of general fund in FY '24. And in FY '25, we made a decision we made a decision to request that be matched with global commitment funds. So that, you know, a little bit more than doubled that. If for some reason global commitment investments or global commitment as we know it today goes away and other decisions have to be made, we would need to change, if there were to be a change of the initial $1 million investment, it would need to happen here. So the department couldn't do that on their own, is what I'm saying.
I don't know why I'm raising it.
So if I'm following, it wouldn't default just back to $1 million
Correct.
of general fund.
It does
Yes,
not
it-
default.
Well, it would. but-
It would.
It would, but it would be insufficient for what we've have with global commitment funds and general funds for 25.
It would mean that there would be $1.4 million less
Okay.
than what they anticipate having for FY '25.
But the $1 million has to intentionally be put back in through general fund.
Right. So it was the long way of saying that, you know, the department can't decide to spend $1 million on some other service that would probably be as equally as beneficial.
Right.
So that would have to be a decision that's made here through the budget process or whatever happens in the summer with joint fiscal committee, et cetera.
Exactly.
Yeah.
More fun.
Yeah.
Um,
Okay, so,
Are we done on this topic for Meals on Wheels?
we have another topic to cover.
Yes, I know. I just
Okay.
wanted to, for transparency, my employer is the Vermont Association of Senior Centers and Meal Providers. So I just want to make sure that everybody knows that. So thanks.
Thank you. Okay, yeah, let's move to the payment of parents.
so Jen, you want to just pull right up here?
Thanks, everyone.
Thank you so much, Jason. So we have slides also.
No, you're fine.
Okay. And all, we said parents, but it is legally responsible individuals technically, and Jen's gonna walk us through.
Yeah, so it's our most recent, so I'm Jennifer Gerbedian, Developmental Disability Services Division Director for the Department of Disabilities, Aging. Thank you for inviting us to talk about our protocol for paying legally responsible individuals. So it is slightly more robust of a policy to include private guardians as well as parents, other family members, non-guardians, and non-parents.
Can you take that extra piece off, Rebecca? Well, the thing that's covering the words. Thank you. Oh, I guess we have to have that on there.
Okay.
Yeah, there you go.
Thank you.
So non-parent and non-private guardians were always allowed to be, or I shouldn't say always, were previously allowed to be paid through different mechanisms. So this is an expansion to include parents and private guardians. And so with our most recent agreement with the federal government through the 1115 waiver, global commitment to health. We were awarded approval to include a protocol for legally responsible individuals. And so we developed that in conjunction with input sessions with individuals, family members, most notably parents, and our direct service agencies. So we built out a protocol that allows individuals and their adult children, I'll probably just call them adults because it feels weird for me to call someone an adult child, who are enrolled in developmental services, home and community-based services, to engage in an arrangement where the legally responsible individual to be paid as long as they're living together full-time. The conditions of payment, great, we're on the right slide. The conditions of payment include when there's a lack of a qualified direct support professional or independent direct support worker. So you often hear those referred to as a DSP, or less frequently an IDSW, result in 50% or less of the authorized services being provided. Allowable services include community supports or in-home supports. Those services, the individual needs to be receiving 50% or less of their services for 45 days or more, or have a complex medical support need, or a complex behavioral support need, or nuanced communication support needs. And then the legally responsible individual can be paid for the authorized community supports or in-home support services up to 40 hours a week. We were asked to put some pretty clear guardrails and safeguards in when we worked with the Centers for Medicare and Medicaid to get our policy approved. And one of them was to have a limit on the number of hours per week that a legally responsible individual could be paid for the services provided. Some of that is to ensure that, authentic family time is preserved. Right now, we have the standard rate of pay based on our current collectively bargained minimum for independent direct support workers. This is sort of our minimum standard, and over time, we can adjust this. So it will be indexed based on that collectively bargained agreement. We enroll our legally responsible individuals through our fiscal employer agent as independent contractors. They are effectively self-employed. And we've also included a number of different quality and controls to ensure person-centeredness, including periodic reviews of the ongoing appropriateness of this arrangement. It's set individualized, so each arrangement has its own review cycle. We have opportunities for the individual to communicate privately with their service coordinator. Once conflict-free case management comes in, they'll also be expected to have similar private conversations with their case manager. We require in-home visits and annual developmental disability quality reviews, so that we're having folks just check in, make sure that the arrangement makes sense, and that the individual is really at the center of this, driving determinations of the appropriateness if they still want their legally responsible individual to be in this care.
Curiosity. So there isn't any double dipping. Eris is separate from you, right?
Yes.
So how do you know, because I know a lot of people that do this, somebody didn't put their adult person into, or I hate to say child.
Yeah.
Adult.
We just say it.
Family member, yeah.
Adult family member, I like that.
Yep.
In Westbrook for the weekend. How do you keep track that they aren't also putting in for themselves to get paid?
Yeah, sure. So Eris has a fairly sophisticated payroll software that will cross-check for that. And so it didn't, you're absolutely right. But so now if there are duplicative services at the same day or time, their system will actually flag for that. And then their staff will review to ensure that that kind of overlapping services falls within the different policies that ours.
Because we got contract with them for our.
Yeah.
That's good to know because years ago,
It
when
absolutely.
I took care of a child with cystic
I heard-
fibrosis,
Right.
I
Yeah,
was just extremely honest. I didn't even put in as much as I should have.
I heard quite a bit about this historically when
Historically.
when I went to visit Aris.
Yeah,
So yeah, they certainly
well,
up.
that's good to
there.
know.
yeah.
That's
It
good
is
to know.
a fairly sophisticated system that.
I just happen to know some people. Yeah.
Lisa Nielsen?
How does Aris get paid? Do they get paid like per patient?
They do have we call it a per member per month administrative fee. So they are able to bill for services provided based on the payrolls that they issue for individuals who are enrolled with them.
And Aris does at-home visits periodically?
So Aris doesn't because they are doing exclusively the financial side of it, but we have right now it's service coordinators who are designated agencies and specialized service agencies that do like in-person visits and as of October 1st, we'll also have case management organizations where case managers will do in-person and.
It's the responsibility of the designated agency. It's ultimately the responsibility of the department. And it will also be the responsibility of the case management entities in conflict free.
What kind of warning does somebody get when it's gonna be an in-home visit?
So it depends, for,
Is it a 1 hour? But I was told 1 hour, which is really not convenient.
it shouldn't be that, it shouldn't be that short of a time frame. For individuals and individuals living with their families, they should be given ample notice that someone wants to schedule an in-home visit. For individuals living in what we call a provider-owned setting, like living in a group home, obviously the agency staff can show up whenever they want. For individuals living with a shared living provider, that's also considered a provider-owned or provider-controlled setting. They have the ability to do unannounced visits. And so they could be getting limited or no advance notice because there may be reasons that they want to show up unannounced and check in on people that they're contracting with.
But the hourly sounds like a team meeting. It could be hourly meetings.
Yeah. Yeah, and so that might, but again, to really do it properly, people should be given advance notice to make sure they're available for a team meeting and do those sort of things.
I personally know someone that had a 1 hour and really stressed her out.
Yeah,
And so there's no like 45 minutes, 2 days, 3 weeks. There's no, it's up to the person doing the thing.
Representative Nielsen, I'm just wondering, do you know the situation? Was it a person, was it a family member or was it a home provider?
With a family member.
A family member?
She's taking care of her mom. She needs help. And she was very twisted how they just gave her 1 hour's notice.
Oh, 1 hour's notice that they would come in.
Yeah.
Oh, so, okay, don't know if there was a reason for an unannounced. Sometimes there was a complaint, just like, I don't know in this situation. But we do not want people to be stressed out by these home visits because it's supposed to be teaming.
should be supportive.
So-
She was really stressed out.
So I don't know when that happened, but not now, but you can send
Yeah,
that
be happy to
yes, and we'll
follow
check
up
into
on
that.
it.
Yeah, I would appreciate that.
Yeah,
Because I
yeah.
told her it's like, doesn't sound right. It happened very recently also.
Right, and actually, the goal is for everybody to be able to work together in a way where everybody feels like productive and not stressed out by it.
Now, this family member, I'm talking, I know her. She thinks that Eris does not want people to take care of it. They want people to get people through the agency. She wasn't happy with people through the agency, so she found people herself.
It's completely within her rights. We should-
And she feels like it's a battle.
Okay. So we are interested in that
Yeah,
complaint.
yeah,
So
absolutely.
we're gonna take that as a complaint right now. and We're gonna
Good,
follow up.
good, thank you.
Okay.
I appreciate that.
Thank you.
Yeah.
So Representative Nielsen, if you, we have contact information for Ms. Garabedian, and you can send her an email with the details and she'll follow up, I'm sure.
Good, thank you, I appreciate that.
Welcome.
We have just some very basic data. This option has been in place since about November of 2024. So it is growing with its accessing this. But to date, we have 34 individuals who have taken us out on that.
She's having technical difficulties.
Oh, so
She's
sorry.
very slow.
Okay, sorry, I got excited because my computer's actually working today. So we have 34 of these arrangements in place. As it turns out, we have, there is the ability within our protocol for individuals who have multiple adults to be enrolled in this and provide support to any and all of their family members. It is 34 legally responsible individuals providing to one individual within their family. There's nothing in our protocol that prevents the legally responsible individual to also be a second caregiver. So if the individual requires 2-to-1 care, it could be the legally responsible individual providing, being one of the caregivers and accessing another individual to provide that 2-to-1 care. We have seen that actually starting to happen, which is a fantastic way for the individual, the adult in the arrangement to be getting the 2-to-1 support that they need. We have 8 of our 16, some of these people are family directing services. So 8 of our 16, half of the agencies or organizations who have been working with families to engage in this option. The first date of payment was in January of this year. And we've had almost 2,000 hours paid through this.
Which is only about 3 months worth of
Yeah,
data. Yeah.
Exactly. We have about a quarter's worth of
Yeah.
data. As you'll see, the majority of the services, 2/3 of the services are paid as in-home supports versus accessing community support hours. Just sort of anecdotally, this seems to make sense. We hear a lot that individuals are less excited about going out in the community with their parents. But certainly this is a way of ensuring people's health and safety is met.
Jennifer, when you were talking previously about participating in in-home visits and quality services reviews, so do things, is that how you were learning about that? How are you learning about individuals, perhaps lack of preference to do community supports with their family member?
Yeah, so that was something that we learned in our early input sessions, that while people appreciated that this was a way to ensure access to services, one of the things we heard was that they weren't they were less excited about sort of doing community supports with their parents. And that, some people really appreciated the idea of having someone that was really well known to them do some of their personal care supports or help them with complex medical needs. But the idea of really accessing the community with their parent was less appealing to them.
Mm-hmm.
Developmentally appropriate.
Yeah, I mean, totally. What about, so I know there's been some difficulty in fulfilling, it's a different program, but same concept. And for folks who have nursing services, and it could occur, I guess, in the developmental services waiver as well, but so is it only those 2 services that are paid for in this way?
Yeah, so as part of developing this protocol, we needed, so part of this protocol is that it's for personal care services or similar services. That's how CMS defines it. And so
not nursing, in other words.
right.
Okay.
Yeah, so that's where, having community supports or in-home services were where we were able to, define this protocol. That's why things like employment are included in here, nursing or some of those sort of higher level services are included in here.
Thank you. And I'm just wondering also, I knew at the outset, Green Mountain Self Advocates wasn't crazy about the concept, but I think they mentioned in testimony earlier this year, as I recall, that they felt like the department had worked to come up with the protocol that you talk about, that they seem to be okay with. Is that seem consistent with what you understand?
Yeah, so initially, there had been conversations with them and they had indicated some concerns around moving forward with this. We did meet with them specifically and held individualized input sessions with them to really understand where their concerns were and hear from them as a group where they felt where they felt the safeguards needed to be to ensure the person was at the center of it, that there would be appropriate places for people to speak privately and be able to agree to it, and then also have opportunity to say, I don't want to do this anymore, but I thought this would work, and I feel like this isn't working anymore. And we built those in. We spent time making sure that they had a safe space to talk with us, and heard them when they said they didn't want to join a larger work group because they didn't want their voice drowned out. I think having time for us to speak with them privately was really valuable, because it was really important, I think, for the division to hear from them in a place where they could just speak honestly and help us really define those safeguards.
Thank you. Any other questions from folks? Go ahead, Representative Bishop.
There was reference earlier to how the pay rate is determined. I'm just doing rough math of dividing 32,000 change by 1981. It's roughly 1650 an hour. Does that sound about right?
Yeah. So right now it is built on what is the collectively bargained minimum, which is about $15 an hour plus the employer tax component, which is almost 12%. So you're right, it's about 16 something. We have the ability again to adjust that as we need to over time. We started with this standard rate because understanding individuals' needs, we don't have a really solid way without a database or something more robust to understand sort of where people are as we move to more standardized approaches to understanding needs, to having standardized rates. I think that will put us in a better position to use something other than this very modest collectively bargained minimum, to appreciate the fact that some of the people who access this have 2-to-1 care needs. Some of the people who access this have very high support needs, and then using tools that are available to us, we will be able
Like the tiers
Like
in
the
the
tiers, yeah.
assessment process that we
and some
have.
of those, I think,
Yeah.
will be in a much better place to do that and have very clear guidance to Eris so they know what rates to use.
And would these legally responsible individuals receive a W-2 at year's end from Eris and?
They receive a 1099.
Sorry.
Yeah, no, that's fine. But yes,
1099.
they receive all of that information from Eris so they can properly fill out their taxes. Yep.
I remember, at least I think I remember, that during COVID, there was some, because of the restrictions on people, there were some payments made to, I guess, with legally responsible individuals. Did you find that when you implemented this protocol that is this more restrictive than what was being done previously? Did you run into any issues with folks who've been sort of accustomed to it being done one way and then now it was being switched.
Yeah, so this is a more formalized approach. You're absolutely correct that this protocol really does tie more closely to an ISA. It does have people work more closely with an agency because it is really intended to replace services that may not be able to be provided as effectively or efficiently by an agency. When we were working with the agency, they felt really, agencies to develop the protocol, they felt really strongly that they wanted to have the connection, the ongoing connection, as opposed to having the case management organization really be the lead on all of this. So I do think that probably people are feeling that it is a little bit more, I don't want to say like restrictive or limiting, but that is a little bit more formalized in that way. I think that it will lead us to like stronger outcomes in the long run. I hear a lot like, is this really intended to be like short term? And well, we're always hoping that people will get the services delivered in the way that they want. There are certainly arrangements that they don't necessarily think need to be considered like short term in duration, especially for individuals who have complex medical needs, have some of those more complex or nuanced behavioral needs, or certainly those nuanced communication needs, where bringing somebody else onto the team to provide those direct services is really more disruptive for the individual than it is beneficial. And so really that adult at the center is the one sort of saying like, it's really hard for me to have new people come in, and I'd really rather have somebody who's known me a long time and knows how to best support me to access the community or get through my day. And maybe it's not just a person who has those complex needs, but somebody who just says, I really don't want somebody else helping me with my personal care. That's really private for me. And so I think that it doesn't have to be short-term in duration, but we wanted to hold that out there for parents who have said also to us, I just want to be the parent. I don't want to be the case manager. I don't want to be the direct support worker. So that's why we're always asking to have it like reevaluated for appropriateness and preserving that authentic.
And for those who are choosing to do it or would have been doing it anyway without any kind of reimbursement, this is, for them, this is a boon, right?
Yeah.
Yeah, and you know, we've all heard the stories of folks who have had to leave their employment and because they've been unable to get services for whatever reason. So as modest as this is, it's a start anyways. Yeah.
And I think this is what I would really want to highlight is this is really our first step in, and we want to continue to evaluate it. And the more that we have some of these standardized approaches that will help us articulate, especially to areas, so that they have a standardized way to be able to pay more appropriately, then I think we'll be in a better position to do that.
It's 3 months in on the data.
Yeah.
So it seems like a good start.
Yeah.
Great. All right, thank you to everyone from Dale. We hadn't heard from you in a while, so we thought we'd have you back. We didn't want you to think we had forgotten about you or any such thing.
Appreciate that.
Yeah. Thanks so much. We appreciate it.
You know, you have all these free hours in your day.
There's been nothing to do.
Yeah, right.
Okay.
Thank you, Commissioner. Good day.
Thank you.
Yeah, family.
Bye. Family members taking care of who can't work out of the home because of taking care of somebody.
Okay, folks, we are switching gears. We are. That's strange. Stranger than. Okay, so we are coming back with H46, which is an act relating to the Rare Disease Advisory Council. We last left off, like this was an ongoing story. We last left off with H46 with the Department of Health going to have some conversations with UVM, and we had the what his official title was, but Dean, thank you. We had the Dean of medical school with us last week, and so they'd asked for some time to be able to kind of like figure out what might work, especially given the particular changes that we've made in the bill as amended. We've made several amendments to our latest draft, significantly changed the bill. So we're joined by Kelly. Do you want to join us at the table? No, Natalie. I didn't know if Natalie wanted to join us at the table or.
Sure.
Either way, if you're going to speak, I'd prefer you to be at the table at some point, even if it's just answering questions.
I don't have anything prepared, but for any questions, I'm happy to answer them.
Great, thank you. Welcome, Kelly. Welcome back, I should say.
Thank you.
So we're at this decision point. I think we've pretty much, I mean, I don't know what you have. I'm not sure if you submitted anything in writing.
I haven't yet, but I do have some remarks that I can send immediately following.
Okay. So, we're at the decision point of, where such an rare disease advisory council would be housed. And we have two options. Given the changes that we've made in the bill and the discussions that we heard from UVM last week and any follow-up discussions that you folks have had, we're glad to have you here back this afternoon to hear your thoughts.
Sure. So thank you. For the record, Kelly Doherty, Deputy Commissioner, Department of Health. Thank you for the opportunity to return to discuss this bill and this important effort to support the rare disease community with the committee. So again, the department recognizes the huge impact that rare diseases have on individuals and families in Vermont and the importance of monitoring and research regarding these diseases. And as we noted the first time that we were here on this bill, we are enthusiastic about the work that we already do at the department in this area and are looking forward to continuing it to help address rare diseases through screening and data collection, partner collaboration, and disease prevention and health promotion. And we do support the important legislative intent of H46 to give the rare disease community a platform to strategically identify and address barriers that prevent individuals living with rare diseases from accessing adequate and effective treatment and care for their conditions. Since our previous testimony, we did reach out to UVM to explore opportunities for collaboration, but we do understand from their testimony that they too have significant resource constraints. And we also recognize that there may be much to learn from what other states are doing in this area. I mean, I know you had the national person here a couple of weeks ago, but to really dig into sort of what are the accomplishments of those councils that exist. So as this work will continue on into the next session, we appreciate the opportunity for further discussion with stakeholders that can help shape the effort and maximize the impact of this work. In its current form, the department is concerned that the deliverables presently specified in H46 are not realistically achievable for a volunteer-based council within the framework of the bill as it's written, and that the department cannot currently volunteer the support necessary to complete these deliverables on the council's behalf. So for example, the H46 requires the advisory council to produce several deliverables. 1, convene and conduct public hearings. 2, create a needs assessment. 3, provide testimony and comments on pending relevant legislation and rules. 4, consult with experts on rare diseases and develop policy recommendations, including recommendations related to newborn screening, quality of care, access, and affordability. And 5, as needed, draft a report to the committees of jurisdiction all within 4 meetings per year. This is a lot of work requiring a high level of policy, medical, and clinical expertise. The department can provide the legal, technical, and administrative assistance required in the bill, but this assistance would be limited to such things as sharing information about open meeting laws, scheduling assistance, maintaining a web page, and providing access to virtual meetings, a virtual meeting platform, and physical meeting locations. The department would not be able to perform research, analysis, or policy and legal work on behalf of the council. The council, composed of volunteers, many of whom are professionals in fields already dealing with time constraints and access issues, would be charged with accomplishing these tasks during its quarterly meetings and on their own time. Also, given the uncertainty regarding the stability of federal funding that currently supports a significant portion of the Department of Health's work, including much of the work already dedicated to rare disease monitoring, it's critical for the department to prioritize its existing efforts in this area and to protect and support the health of all Vermonters. But we do believe that the goals of H46 can be met without the required activities currently listed in the bill. So we would recommend making the list of activities for the council a set of options, so using may instead of shall. This will allow the council to have a voice while working at the pace that its resources allow. The department could offer technical, administrative, and legal assistance to support the council as it works through these efforts. And we support the intent, like I said before, to establish an advisory council and whose work in this important space can be meaningful and productive. The recommended change, the shall to may, would allow more time for stakeholders to identify efforts that best fit Vermont's needs and empower the advisory council to articulate its own goals and resource requirements themselves. So again, we welcome the opportunity to continue conversations with the legislature and other stakeholders to find the most appropriate and impactful way to support the rare disease community in Vermont. Again, I just really want to articulate the immense uncertainty that exists in the health department right now, given the extent of the federal funding that supports our work. That's pretty much sums up my remarks, and I'm happy to take questions. That's it.
Okay. Okay. Thank you, Deputy Commissioner. I think that's actually really helpful feedback, in terms of that. And, I think that, as I look at the duties or expectations, I can see that there are things that I think actually probably go beyond what a rare disease advisory council would do, like whoops, this went in the wrong direction. Advance affordable and comprehensive healthcare coverage. Okay. That's laudable. We all want that. And there are other places and people who are working on that. And I think it's more related to making sure that people with rare diseases have access to, appropriate healthcare services. And so I can see definitely where there is some room for one, being really clear about what some of these things are, and two, as you said, I mean, we thought we were doing great strides when we reduced it to 4 meetings. We're trying to reduce the workload, but also trying to accomplish all of these things within that context. I mean, I think your recommendations allow the department to, not the department, but allow the department to be providing assistance, but allow the group to move at its own pace and decide, which of the things, of the menu of things that are important that they would find most relevant to improving the status of healthcare and long-term care services for themselves and the people that they support. So appreciate that very specific feedback. And then I remember having a conversation with someone, I don't remember if it was Natalie or if it was Kelly, I think it might have been Natalie, that that's identifying conditions that should be screened, that even though on the federal level, the current administration has done away with the advisory committee that the state has depended upon, there actually already is an advisory committee that looks at this. Am I remembering that right, Natalie?
Yes, you are. The department hosts an interdisciplinary committee that has individuals from the lab who can speak to what tests are possible, how much tests are, physicians. I was just pulling up my notes. I have the notes on another screen here.
Yeah, that's okay. What would be helpful is, so I can see us modifying this. If you could give us the name of that group so that, we can, maybe put as one of the menu options for this group to work with, or to advise, that group that you already have rather than, duplicating something that they're already doing.
Thank you for bringing that up. Yeah, I'd be happy to send you, and Katie McClure.
Yeah.
The name of that group, I have it right here.
Okay.
It's it is the Newborn Screening Advisory Committee. And like I said, it's facilitated by the Department of Health. It's interdisciplinary, lab, hospital, specialty, family payers. And this committee makes recommendations to the Department of Health's newborn screening program on additional diseases and conditions that could possibly be added. And then Vermont specific logistics regarding lab testing and other major policy considerations. So it is similar to what the Rare Disease Advisory Council would be doing.
On that newborn screening aspects, yeah. So I think that we would just cite that. And is that established in statute someplace, or is that just something that?
That's something that the program chooses to do to
Okay.
get feedback from these interested parties. So
Yes.
it's Department of Health initiated.
So I'm imagining that they will need to adjust to the fact that they're not going to have this federal advisory group that I'm presuming had informed some of their work.
So yes, this is a work in progress. We're sort of learning as things unfold.
Yeah.
And watching to see, of course, it's not just Vermont that the disbandment of this federal
Yes.
group is affecting. So we're looking at our state partners to see what they're doing, and we're deciding what our next steps are going to be once the dust settles a bit. But even today, I received an update on potential next steps. So really, it is every day we're learning something new.
And that too will change. By whatever the next announcement is. Okay. So I just want to make sure to summarize what I think I'm hearing, to make sure that we're on the same page. So I'm hearing that the department is willing to provide the administrative consultative, the webpage assistance, changing shall to may. In other words, looking at these things, however, they're modified as options for the group to consider. And I do see us probably still even reducing a couple of these things, like, the broad healthcare affordability, because it references the things that would be specific to people with rare diseases. So I wouldn't expect this group to advance the broader issue of healthcare affordability and delivery. And there's no reason to replicate something that the department already has an advisory committee on. So
Mhm.
that's why it's always helpful to work with our partners in the administration to understand what's there and what's not. So with those types of changes, and I'm hearing you say that you would be supportive of this if we could make those kinds of changes.
Yes.
Yes? Okay. All right. I didn't want to make any assumptions.
No.
Representative Donahue.
Just want to say, I was having this internal discussion in my head while you were testifying. And I was like rebutting everything you were saying, but they can choose what they can accommodate doing. They are volunteers, but they can decide their priorities and all. And then you got to the point where you said, the may instead of shall. I said, you mean we said they had to do all that?
Gosh. That's the way I took it too, is that they had to do it, and I'm thinking, that's wrong.
That's too much, right?
Too much.
No.
I even I sent her an email.
Okay, are there any other questions for the witnesses? We really appreciate you being here today and following up with us, and we'll definitely work on a new draft and send that off to you to take a look at. And if you, other than what you've already said, if you have anything else specific, feel free to send them to Katie. It's fine.
I will do that.
Okay. Thank you both for being here. Appreciate it very much.
Thank you so much.
Alrighty, take care.
Bye-bye.
Oh, wait a minute. I'm sorry. I didn't see
It's
it.
not about this. I mean, it's not about this particular, I'm just wondering, so let's say we accept all this and it works and go forward. Then the advisory committee could come back to us with recommendations, but they actually need certain kinds of support or something like that, where it then,
Yes.
is that our responsibility then to sort of negotiate how that gets done? Like,
Well, it's like-
negotiate with the department or?
It's like any advisory committee. So they give advice, and then the people who they're giving it to decide whether to take it or not.
Right, exactly, okay.
That'd be us too.
Yeah,
Yeah,
okay, just one.
yeah, Dan.
A good example, the Alzheimer's Association, I mean, the Vermont Commission on Alzheimer's and Related Disorders, the other part that they would expect something like what this, like,
Yeah.
what are the legislative priorities, what's going on?
I can imagine them getting, quite enthusiastic at the beginning and it might not really be workable.
And we might not have the money.
Exactly.
Any other questions?
Sorry.
No, that's no apologies necessary. Okay, great. Thank you both for being here. Appreciate it very much.
Bye-bye.
Bye-bye.
But
Is the treasurer still on tap?
I have not heard that he isn't.
Okay, that's great.
Encouraging.
So the treasurer is supposed to be joining us via Zoom in 5.5 minutes or so.
H13.
And that's for H120.
Oh, back, okay, still on 120.
Yeah, H13 is now passed.
Yeah.
That's gone, that's
Yeah.
moving to the
I get them all
governor.
mixed up, all my numbers.
So do I.
Yeah.
I do, I was trying to think
Don't
it
give me
was
the
number
right
one,
What
but.
you're talking about.
It's even worse.
Mixed up all my numbers.
It's even worse when the bill numbers turn to act numbers
Yeah.
after they've been
Right.
passed and signed.
Yeah, and that's what like
Very
people
confusing.
ask about after they've been passed.
Yeah.
We can go offline.